Hey guys, welcome to case 6. So let's go right into it. We have a 10-year-old boy brought to the physician by his mom for 8 months of progressive fatigue and weight loss. His mother reports, mother reports that during this time he has become a picky eater, so his appetite's changed. He often has loose stools and complains of occasional abdominal pain and nausea. Family moved to a new house 9 months ago. He is at the 50th percentile for height, 25th percentile for weight. So his height is normal, his weight is low. Temperature is 36.7, pulse is 116, and blood pressure is 85/46. So he's tacky and hypotensive. Physical exam shows tan skin and bluish-black gums. The abdomen is soft, non-distended, non-tender. Serum exam shows sodium of 134, potassium of 5.4, bicarb of 21, BUN 16, glucose 65, and a creatinine of 0.9. So I've highlighted some of the key facts here for you. And after IV fluids, what's the next step in treatment? So I'll give you a second to pause here and read the answer choices, decide on what you think is correct, and then we'll go through them together. Okay, so if you picked glucocorticoids, boom, you would have been correct. This kid here has Addison's disease, so that means our adrenals aren't working. All the layers of the adrenals, right? So aldosterone's not working, cortisol's not working, the adrenal medulla is not working, our catecholamines are down, right? So those can justify what's going on. So he has fatigue and weight loss, probably from the low cortisol. Loose stools, abdominal pain, and nausea, that's also associated with the low cortisol and the changes in the volume state. Then he has had this been going on for 8 months, so it's a bit of a chronic picture, okay? He has low weight again, then he has hypotension, right? And tachycardia, most likely from the hypotension to compensate. Now why does he have hypotension? Because his catecholamines aren't constricting his blood vessels anymore, so they're dilated and his blood pressure tanked. Then we have tan skin and bluish black gums, and this is probably a result from the excess MSH that's being produced. So our adrenals are failing, our pituitary is going nuts trying to stimulate it with ACTH, but in the process of making ACTH, you guys all know that ACTH comes from a compound precursor called POMC, which makes both ACTH and something called MSH, or melanocyte stimulating factor. Now MSH can cause your skin to darken, and it also causes your gums to darken. So as you can see in this picture here on the bottom left, you have darker gums. Then if we're looking at the electrolytes, we have low sodium, high potassium. That's an low aldosterone kind of picture, right? And also the low sodium is a result of low ADH, because I'm betting a lot of you didn't know this, but the cortisol also works to inhibit ADH release from the pituitary. So if you don't have cortisol, ADH absorbs a lot of water in the distal tubule of the kidney, and we have a dilutional hyponatremia. And then if you calculated the anion gap here, you would have noticed that here our bicarbonate's low, right? So we have an acidosis. This is a non-anion gap acidosis, which is seen in Addison's disease. Okay. Then our BUN is also a little high, likely because our volume state's low, so we have a pre-renal kind of shock to our kidneys. And our creatinine is 0.9. So BUN to creatinine is not 20:1, but our BUN is going to rise because of our slightly altered volume status. Then we have a glucose that's low, and that's again because of the cortisol. Our glucose metabolism is changing, and it's going to be low because low cortisol, low glucose. Let's go through each of the answer choices one by one and kind of eliminate them. So glucose-free diet, gluten-free diet, sorry. This is associated with celiac disease. It does have things like diarrhea, abdominal discomfort, weight changes, right? So those do support it, but we don't really have hyperpigmentation in celiac. If we're going to expect any kinds of skin changes in celiac, it would be dermatitis herpetiformis, right? That's our classic herpes-like rash. Or we could have something like a hypopigmentation vitiligo picture. Remember, autoimmune diseases like to travel in packs sometimes, and they're usually tested in packs. So sometimes they'll tell you about one autoimmune disease and assume that you'll know that the prevalence of another one is higher in this person. Then again, if we look at the potassium state, if we have celiac, we have a lot of diarrhea. And what does diarrhea do? It tanks your potassium. So because you're pooping it all out, right? Tanks your potassium, tanks your bicarb. So we wouldn't have hyperkalemia in this case, we would have hypo. Then levothyroxine. Now this is pointing you towards hypothyroidism. So fatigue, changes in energy, changes in appetite, potentially justifying hypothyroidism, right? But it doesn't give us too many of the other key symptoms, right? We don't have constipation, we don't have weight gain, in fact we have weight loss, our kid is in the 25th percentile. We don't have hypertension, we have hypotension, okay? So hypothyroidism is associated with hypertension because thyroid hormone causes endothelial constriction. So our tension actually would have gone up. TSH causes endothelial constriction. So our tension would have gone up instead of down. Then loose stools, weight loss, and hypotension not really fitting with our hypothyroid picture. We would have constipation here instead of loose stools, weight gain, and hypertension. So those are opposites. Cold intolerance, dry skin, hair loss, hoarseness, edema, all these hypothyroid pictures are also not given. And the electrolyte changes and hyperpigmentation aren't really explained either by this condition. Now fluoxetine. Fluoxetine, I'm betting a lot of you didn't pick this one. You're thinking, why would I give an SSRI for this sort of condition? So fluoxetine is given actually for two things. It's given for MDD, and you could say that the fatigue, the appetite changes could be supportive of an MDD picture. But if they're really looking to give you MDD, they'll give you 5 of the 9 SIGI-CAP symptoms, right, for at least 2 weeks. And this is a chronic picture. Now, a lot of you probably didn't know this, but fluoxetine is also used for IBS, so irritable bowel syndrome. That's where your gut is a little bit leaky, a little bit permeable, you're getting alternating constipation, diarrhea. The pathophysiology on IBS is a little iffy, but make sure not to mistake this with IBD. IBD is Crohn's disease and ulcerative colitis. That's the more severe version. So that's like IBS with alarm symptoms, IBS with bleeding, IBS with waking up at night because you need to stool or you have abdominal pain. That's when an IBS kind of should be confirmed whether or not is actually a really severe IBD. So remember that those are different things. And fluoxetine can be used to treat IBS. The exact mechanism, I'm not sure. Then, so again, the IBS and the fluoxetine doesn't explain our hypotension and our hyperpigmentation. So really not a great answer choice here. Glucocorticoids, of course, is our correct answer. So whenever you have Addison's, you want to give glucocorticoids because they not only work as the function of cortisol, they also have a slight mineralocorticoid action, so they also correct a little bit for aldosterone. So it has a double-edged sword there, okay? The hypotension, again, is due to the low catecholamines because our adrenals are one of the main producers of catecholamines in our body. Then we have decreased serum glucose because cortisol is integral for peripheral glucose utilization, right? It's going to cause utilization of glucose peripherally to go down. So now we have high peripheral glucose utilization in our Addison's patient, and our cells are absorbing more glucose. Also, gluconeogenesis is going down. Again, cortisol causes high blood glucose, pushes more glucose into the blood, okay? Then we have a dilutional hyponatremia. Now, a lot of you, like me before, would have thought that this hyponatremia is due to the aldosterone being low. So aldosterone's low, you have less absorption of sodium and less shooting out of potassium. So the aldosterone could explain the potassium, but the hyponatremia is really due to antidiuretic hormone. Now you're thinking, oh, antidiuretic hormone, that's made in the pituitary, right? Why are we looking at the adrenals? Well, cortisol actually has a negative inhibitory effect on ADH production in the pituitary, so just watch out for that. Hyperpigmentation, this is a result again of our MSH, so our adrenals in primary Addison's, which this child has, is not producing its hormones, so we don't have any negative feedback. Our ACTH is being increased and pumped out. And what is a precursor of ACTH? It's POMC, which makes both ACTH and MSH, or melanocyte stimulating factor. Now, if you have a lot of MSH, you're going to have this really, really nice tan going on because all your melanocytes are producing excess pigment. Even though you didn't go out in the sun, even though you're not a sunbather, you're going to have a sweet looking tan. So watch out for this. It's a very subtle symptom. And the good part about the MSH, at least from a diagnostic standpoint, is that you know the cause of your Addison's is primary. So if the adrenals aren't working, then you'll have the high MSH. And that identifies primary Addison's, where the adrenals are the problem. Secondary Addison's, ACTH is the problem, remember, and tertiary Addison's, it's the CRH from the hypothalamus that's the problem. So go one step back in the chain of the hypothalamic pituitary adrenal axis to get primary, secondary, tertiary Addison's. Then we have our hypoaldosteronism, right? This could explain again our hyponatremia to a certain degree, hyperkalemia for sure, and it also explains our non-anion gap metabolic acidosis. Remember, aldosterone is also responsible for shooting out protons in our distal tubule. So if it's not there, you have an acidosis picture. And the sodium also helps retain water in our bloodstream, so it again explains potentially our hypotension. So catecholamines and aldosterone for sodium, then again hyponatremia is really our ADH and our aldosterone again. Hyperkalemia is explained by our aldosterone. Okay, so I hope this has been a good review on Addison's for you. Let's move on to hyperbaric oxygen. This is really pointing to carbon monoxide. I bet not a lot of you picked this because usually if they give you this, they'll give you a source for the carbon monoxide, a poorly ventilated room, a house fire, exhaust, even excessive pipe smoking can cause this, okay? So the old granddad that smokes a pipe for 12 hours a day, watch out for carbon monoxide. So we don't have a source, which is not a great. We just have an old house, which I guess you could justify that the ventilation systems in there could be poor. And carbon monoxide doesn't really explain our hyperpigmentation of the skin or the gingiva, okay? So really not pointing to that. And if we're looking for a acidosis in carbon monoxide poisoning, we would have an anion gap, right? We would see an anion gap metabolic acidosis, right? Not a non-anion gap. Why? Because now we have a bunch of lactate production. Remember, our carbon monoxide is taking the spot of our oxygen. So now that we have no oxygen going around, we have increased anaerobic metabolism, which produces a bunch of lactate. And remember, in our mud piles mnemonic, L in mud piles is lactate, right? So anion gap acidosis. Next, we have our RIPE therapy. So this is RIPE, just not put in order for you to make it a little trickier. This is for active TB. And if they were giving us active TB, they'd probably give you a little bit more about the lung symptoms. So some dyspnea, some hemoptysis, some night sweats, fever, things like that. The child will also be mentioned to be from some sort of third world country. And although TB can cause Addison's disease, right, TB can affect the adrenals. The problem with that is that even though it could be caused by TB, you first want to treat the Addison's before you address the TB. So even before you do a PPD or a interferon gamma assay to check for TB, you'd want to have the Addison's and the electrolytes resolved first anyway. And just to go on a quick tangent, remember the PPD has a 5, 10, 15 millimeter rule, right? So 5 millimeters is positive for people that are immunocompromised, so your HIV patients, or if you have a known exposure with someone with TB, then 5 would be positive. 15 would be something for healthcare workers, or sorry, no, 10 would be for healthcare workers, would be positive, so your potential exposure, and 15 is positive for everyone, okay? So if your PPD is positive, and this is a tricky question that they love to ask, so let's say you're 5 or 10 and then you have a risk factor and you're considered positive. If you're 15 or above, you're positive no matter what, okay? So you're positive on a PPD. You have one of those sizes that's positive with or without risk factors, okay? And what do you do next? You do a chest x-ray. Now the chest x-ray is going to tell you if you have active or latent TB. So let's say even if you have a 15 millimeter induration, you have a negative chest x-ray. That's latent TB. Do you use RIPE therapy for that? No. Okay. For latent TB, if the x-ray is negative, you're just going to do isonize at 6 months. So it's not RIPE, 2 of them for 4, or what's the mnemonic? 2 for 4 and 4 for 2 and 2 for 4, right? So 4 of these drugs for 2 months, and then 2 of these drugs for the next 4 months. That's kind of how you remember the regimen. And then it's isonized for 6 months if it's latent TB. So that means just your PPD is positive, and your x-ray is negative. Here is if your x-ray is positive. You need a positive x-ray for this. Okay, so that's just a little tangent on TB. Remember our 5, 10, 15 rule. 15, everyone is positive. 10, if you are a healthcare worker, you're positive. 5, if you're immunocompromised or you've met someone with known TB. Okay. Next, we have deferroxanine. So this is our treatment for iron toxicity, right? Deferroxamine and deferrazarox. So deferroxamine is used for acute iron toxicity, right? And how you remember deferroxamine versus deferrazarox with the ox at the end is that the earlier the ox is in the word, that the earlier the treatment is. So if the ox is earlier, it's acute. If the ox is later, it's for chronic. Now our kids had symptoms for 8 months, right? So that's instantly chronic. So this would definitely be deferrazarox if they really wanted to point you in that direction. And you would have GI symptoms, right? You could have that metabolic acidosis. Remember, our mud piles mnemonic, I is iron, but again, it's a anion gap positive metabolic acidosis. Which is not seen in this patient, so that's another thing that crosses it off our list. The stools would also classically be very dark, right? You could be bleeding, you could have an ulcer from the iron's oxidative stress on your stomach. Remember, it causes Fenton reaction, which causes increased reactive oxygen species, damage to your mucosas. The patient's symptoms have been present for many months, right? So if you're looking at someone with chronic iron overload, you're looking at hemochromatosis. And hemochromatosis can present with bronze skin, right? Remember, our patient did have darkened skin, which is seen in this patient. But there's a couple things that aren't seen, such as hepatomegaly. We don't have that. We don't have heart failure, arthralgia. We don't have any diabetes sort of picture. Remember, our blood glucose is low in our patient. It should be high if we're having a hemochromatosis sort of picture because our insulin's not working. And again, age is another thing that we really need to consider for this patient. We have a young patient here. People with hemochromatosis are usually present in their 30s because it takes a long time for that iron to accumulate. So again, age doesn't point to this answer. And finally, succumber. I'm betting a decent amount of you picked this one because you saw the gum discoloration and instantly thought, oh, that's a Burton line. That's a lead toxicity indicator. And also the fact they moved into a new house. So houses built before 1978 tended to use lead paint, and that lead paint likes to flake off of the walls, or the kids like to chew on things so they can potentially eat some of the paint. Now, if lead concentrations are greater than 45 micrograms per deciliter, that's lead poisoning, and you're going to have things like colics, intestinal colics, so that explains the abdominal pain. Anemia could have explained the child's fatigue, but there were really no neuro symptoms, so they didn't give you wrist drop, they didn't give you foot drop, and they did give you, though, the bluish black discoloration of the gums. So the skin discoloration is not explained, but the gums you might have fallen for. And here's an example of a Burton line. So you can see how it kind of looks, or kind of can be confused with our Addison's gum picture. But if we're looking at other symptoms like our hypotension, our hyperkalemia, and our neurologic symptoms being absent, that really doesn't point towards a lead picture. So we've gone through all the answer choices. Let's do a little bit of a conversation on diagnosing our low adrenal states, as I promised in the last case. So in low adrenal states, you're going to have low sodium, remember, okay, because of our aldosterone, it's low. Also, our ADH is going to be high because cortisol inhibits it, and that's not inhibiting it anymore. So dilutional hyponatremia. Hyperkalemia from our aldosterone, okay? Normal anion gap metabolic acidosis, again, from our aldosterone. Hypoglycemia from our cortisol, all right? And increased serum creatinine and BUN from hypovolemia. So we saw our increased BUN in our patient. Why? Because our sodium is not being pulled in, and now we have a low volume state. It could also contribute to our potential low blood pressure and tachycardia, although we talked about the low blood pressure being mainly caused by the low catecholamines. So to diagnose Addison's or a low adrenal state, our first test would be a cortisol level, okay? So cortisol is our main indicator for our adrenal functioning, okay? And if it's really low, so less than 3, less than 80, we're having a low cortisol picture. And normally, after we've seen that our cortisol is low, we want to know, why is it low? Is it low because our hypothalamus isn't working? Is it low because our pituitary isn't working? Is it low because the adrenal itself isn't working? Remember, that's how we differentiate primary, secondary, tertiary. So we're looking for primary first, number one, okay? So we're going to do a cosentropin test. Now don't let cosentropin fool you, it's the same thing as ACTH, right? So we're going to measure cortisol before we give cosentropin and after, and then we're going to see the cortisol levels. Now, if the cortisol levels fail to rise greater than 20, okay, this confirms our primary adrenal insufficiency. So we're shooting ACTH at our adrenals and they're not responding. Boom, they're the problem. But if it does rise, we're looking again to see secondary or tertiary, right? Secondary, so ACTH caused, or tertiary CRH caused adrenal insufficiency, the cortisol will rise because now we're supplementing essentially something we don't have. So in those cases, that differentiates our primary from our other causes. So our next confirmatory test that I want to talk about here is the metyrapone stimulation test. Essentially, this test inhibits the 11-beta hydroxylase enzyme. And here's our adrenal axis hormone production, right? You'll remember this from the STEP notebook. Essentially, it takes you from the synthesis from cortisol all the way to the end products. Now, if we look here at our zona fasciculata, I'll zoom out for a second. Zona fasciculata is where our cortisol is made, right? And if we inhibit this 11-beta hydroxylase enzyme, which is what metyrapone does, we're essentially inhibiting this final step here, going from 11-deoxycortisol to cortisol, right? So our cortisol production will go down, all right, in our metyrapone test, if you are physiological, right? So the cortisol production is going to go down, and what's going to happen when that happens if you are normal and your cortisol go down? Right, ACTH and CRH are going to go up. So ACTH and CRH are no longer negatively inhibited, so boom, they're going up. They're going to come back around, stimulate the heck out of this pathway, and increase cortisol production. Okay, so you can see kind of how this metyrapone ultimately leads to increased cortisol production in a normal person. So that's our physiological response in a person that I've mentioned here. So just remember that pathway, and we'll go through the responses. So we just went through physiological: metyrapone, decreased cortisol, increased CRH, ACTH, and then we have increased adrenal synthesis of steroid hormones, and then we have 11-deoxycortisol and cortisol going up. Now, in a primary adrenal insufficiency case, where our adrenals are not functioning, right? Again, our cortisol synthesis goes down, our CRH, ACTH goes up, and because we cannot produce our steroid hormones, they both go down, all right? Now, again, you can't use this test, just like with the cosentropin test, to differentiate primary from secondary. You'll have to do an additional ACTH or CRH level to do that. But essentially in the secondary and tertiary, the levels also go down. Why? Because again, in this pathway, our cortisol goes down because we're inhibiting the pathway. And now our CRH and ACTH, they're not being produced. They should go up because the negative feedback is stopped. But because our hypothalamus or our pituitary isn't working, they aren't functioning. And this ultimately leads to, again, decreased 11-deoxycortisol and decreased cortisol. So if you're normal, we should see an increase. If you're deficient or you have Addison's, we should see a decrease. And then again, you're going to want to get an ACTH level to differentiate between secondary and tertiary for both the cosentropin test as well as the metyrapone test. Now, if we're looking for a diagnosis of something like hypoaldosteronism, we really don't want to focus on our cortisol, right? We're going to look at our plasma renin. Now, because there's no negative feedback and because our blood pressure is low, we're going to have an increased plasma renin concentration with a decreased aldosterone level. That should just make sense. And now, if we're looking at our sex stromal hormones, right, our testosterone is also made in our adrenals. It's not really going to be affected in Addison's because the gonads are the main producers of those hormones in the body. But one of the key things that is often tested is that DHEAS, right, is specific for the adrenals. DHEA can also be found in the testicles, but DHEAS type is specific for the adrenals and it's going to be decreased. If they ever give you this hormone, look at the adrenals in the answer choices because you might find the answer there, okay? So just very quick clarification on that. So I know this was a bit of a longer case. We went through a lot of information. If you have any questions or any concerns about this question, feel free to leave a comment down below. And as always, I'll see you in the next video.